Topic today is managing your risk with a shoulder dystocia. It's very true now that risk management and patient safety efforts are being targeted toward the most preventable and debilitating outcomes in the various specialties. Shoulder dystocia that eventuates in permanent brachial plexus injury is certainly one of those outcomes. Today, we hope that you'll leave this lecture more skillful and informed as a clinician who's dedicated or will dedicate their career to obstetrics, whether you are a midwife, family physician, or obstetrician. The objectives for this presentation are to review the nature of and risk factors for shoulder dystocia and brachial plexus injury, to learn whether shoulder dystocia and brachial plexus injury are preventable, to learn the threshold of force that may cause injury to the brachial plexus, to use simulation to learn through feedback the forces exerted in applying traction, to learn to recognize when force exceeds the threshold for injury to the brachial plexus, and to review how to manage shoulder dystocia with the performance of the proper maneuvers. By way of disclosure, I have no financial interest in any of the products mentioned in this presentation and used in training with the products mentioned, and I have no conflict of interest that would influence the material in this presentation. Recognizing shoulder dystocia is important, very important, since a shoulder dystocia event triggers specific risk management decisions. One is the call for help. That is the assembly of a team of nurses and other assistants to manage the event. A second is the proper performance by the team of the accepted maneuvers to disimpact the shoulder. And finally, and most important in supporting a defense to a malpractice claim, is meticulous documentation to create an accurate record of the event. You see on this slide the two definitions that are widely used to define the shoulder dystocia. Whether you decide to use the delivery interval between head to body that exceeds 1 minute, or the delivery that requires more than just gentle downward traction, really doesn't matter. What matters is how you manage and document the delivery. That is of utmost importance. This progress note is required by my hospital in all shoulder dystocia deliveries. It includes all the essentials to accurately record the event and provide an opportunity to clearly document the essentials necessary to defend a malpractice claim. These essentials include the time interval between delivery of the baby's head and body, which shoulder was impacted under the symphysis pubis, which maneuvers were used to disimpact the shoulder, the head position. This is important to help corroborate which shoulder was anterior, and verifications that fundal pressure was not applied, because, as we understand, it further impacts and exacerbates the shoulder. And finally, whether lateral traction was applied or not, and if it was, an explanation for that. There's also an option to bypass this written documentation and provide a dictation. On this slide is a more concise note that's taken from the HCA system. It too covers all of the essentials as well. HCA has been a leader in risk management and patient safety throughout its hospital system. In fact, studies from that system report significant decreases in adverse events and malpractice claims from those efforts. How often does a shoulder dystocia occur? Well, first let's consider some reality. You know that obstetricians and labor and delivery nurses are afraid of lawsuits and they're very risk averse. So why focus attention on a difficult delivery? Why call a delivery a shoulder dystocia delivery if you don't have to? Because of this reporting bias, shoulder dystocia could be significantly underreported. Using almost uniformly retrospective chart reviews, the most recent American College of OBGYN Practice Bulletin on Shoulder Dystocia, which actually is from 2002 and is now almost 10 years old, states that shoulder dystocia occurs in 0.6 to 1.5% of deliveries. On the other hand, injury to the brachial plexus occurs in a very wide range reported by the college of 4 to 40%. I see in my review of retrospective studies a figure more around 10% of shoulder dystocias, although I've used a lower incidence here. It's also important to remember that of the shoulder dystocias that evolve or eventuate into brachial plexus injuries, only 10% of those are permanent injuries. Translated into numbers, in North Carolina, for example, where there are 126 or 7,000 deliveries in 2009, in Georgia there were about 140,000 in the same year. We would expect about 1,900 shoulder dystocias to occur. Using a 10% risk of brachial plexus injury rather than 5%, one would expect about 190 brachial plexus injuries. Since 10% of those brachial plexus injuries would be permanent, then 19 to 20 rather than the 10 shown would be permanent injuries such as Erb's and Klumpke's palsies. Georgia, as I said, has about 140,000 deliveries, so the numbers would be about 10% higher. Quick review of the anatomy of the brachial plexus. This plexus forms from the ventral branches of the nerve roots exiting from the foramina of C5 through T1. This provides both sensory and motor function to the entire upper extremity. As you can see, there's quite a bit of circuitry, with the higher levels innervating some of the lower levels and vice versa. So many brachial plexus injuries are dense but not complete. This diagram displays the areas of innervations by the brachial plexus. Generally speaking, Erb's palsy involves the upper plexus, C5 through 7. Patients with Erb's palsy cannot raise or flex or extend the arm very well, but they have use of the hand and fingers. These upper plexus injuries seem to involve bruising and stretching more than tearing and avulsion. Klumpke's palsy involves the lower plexus, C8 through T1. This adds disability to the hand and fingers and sometimes causes Horner syndrome. It seems that these lower trunk injuries involve irreparable avulsion of these nerve roots. Neurosurgical adhesiolysis and grafting are very expensive and mostly futile. Orthopedic procedures to reroute tendons and ligaments from neurologically preserved muscles may improve function in some cases. Permanent brachial plexus injury is serious, very serious. Lower plexus, Klumpke's palsy injuries are especially disabling. Take, for example, this quote from an actual lawsuit. MH is now 3.5 years old. She has a lot of difficulty with daily activities. She cannot raise her right arm over her shoulders. She is constantly in pain. She faces 3 orthopedic procedures after having undergone a neurosurgery procedure without success. And now her choice of vocations is severely limited. Her earning capacity is also limited. In this case, the plaintiff seeks a reward of $6 million. In a case such as this, the expected verdict range, if the claim is taken to trial and the jury sides with the child, would be about $500,000 to $800,000. To give one insurance company's experience let's take a look at the experience of MagMutual Insurance Company over the last 10 years. MagMutual insures over 17,000 physicians in the Southeast. The most 13,000 of these are physicians in Georgia, North Carolina, and Florida, and account for most of the malpractice activity. In this 10-year period, MagMutual had 152 claims alleging permanent brachial plexus injury. The company paid indemnity on 20% of those claims, so 80% of those claims were closed without any payment. 39 cases are still pending. In all, the insurance company, using physicians' premiums, spent or has set aside $31 million for total cost and indemnity for these 152 claims. The largest payout was $2 million, but the average cost per case is $390,000. $390,000 exceeds the average claim payment by at least 50% for MagMutual. $390,000 also computes to about 10 years worth of premiums for an OBGYN. Numerous risk factors are discussed in the literature addressing this problem. Most of the risk factors are pretty logical from an obstetrical standpoint. Some of the most common ones are maternal obesity, maternal diabetes, the inadequate pelvis, excessive fetal weight, protracted labor, operative vaginal deliveries, and previous shoulder dystocia. I want to emphasize that this is not an all-inclusive list. Let's address the evidence surrounding these particular risk factors. This table summarizes an old study from Dallas that is found in many earlier editions and also the latest edition of Williams Obstetrics. As you can see, almost half of the cases of shoulder dystocia, 42 out of the 97, occurred in babies weighing less than 4,000 grams. Shoulder dystocia is thus not confined to the macrosomic baby. This is unsettling, at least to me. However, as the fetal birth weight increases, so does the risk of shoulder dystocia. 19% of babies heavier than 4,500 grams had shoulder dystocia in Dallas at Parkland Memorial Hospital. The question then arises whether there is a level of macrosomia sufficient to warrant an elective cesarean section to avoid a shoulder dystocia and a potential brachial plexus injury. Several studies have looked at the risk-benefit of cesarean section at 4,000 grams. All found a marked increase in the number of cesareans necessary to prevent just one case of permanent brachial plexus injury. One of the cost-benefit studies found that an additional 2,345 cesareans at a cost of almost $5 million in healthcare dollars would be necessary to prevent just that one case of permanent injury. But there are some helpful guidelines. The American College of OBGYN, cautiously avoiding the promulgation of a rigid standard of care, recommends quote-unquote consideration of cesarean section when the estimated fetal weight exceeds 4,500 grams in a diabetic patient. And the upper limit for safe vaginal delivery seems to be set at 5,000 grams. Passageway, that is the pelvis, is a risk factor that is not addressed very well in the literature. The pelvis in the male is uniformly android, the pelvis on the far right. In contrast, during childhood, the female pelvis is malleable and sensitive to the timing of erect posture, weight, and level of activity. These influences may play a significant role in determining the mature woman's pelvic shape. In fact, a study of the X-ray pelvimetry of images of over 600 women by Abbott Ball in 1996 out of New York determined that the relative percentages of pelvic shapes in the population consisted of only 40% gynecoid. More than half of women do not have a classic gynecoid female pelvis. In fact, almost 25% have a male or android pelvis. The outlet of the android pelvis is narrow. Also consider the relatively ovoid shape of the patellopoid pelvis and how it affects the anterior-posterior dimension of the passageway for fetal shoulders. Let's consider now the events of labor. A previous shoulder dystocia confers an increased risk of recurrence. College has weighed in on this risk factor as well. In the practice bulletin that I mentioned earlier, the risk of recurrence ranges from 1 to 17% from published studies. And for that reason, the guidance provided by the college is to consider other factors such as the estimated fetal weight of the present baby compared to the shoulder dystocia baby and other factors in the previous delivery. The college discourages universal cesarean for a previous shoulder dystocia based on the fact that most women will not have a recurrent shoulder dystocia. And after consideration of all of these factors, the college guides us to accept either vaginal delivery or cesarean section, the woman's choice. Forceps and vacuum deliveries confer a relative risk range of 5 to 28 times, translating to a 5 to even 30% risk of shoulder dystocia, but that depends upon the station of the head and the number of other risk factors. This was addressed by Bofill at the University of Mississippi Medical Center in a study of 637 patients randomized to either vacuum extraction or forceps delivery. In that study, vacuum extraction, more than forceps, the length of labor, and birth weight were the three most significant predictors of shoulder dystocia. So in conclusion, no risk factor or combination thereof seems to be predictive enough of shoulder dystocia to warrant prophylactic cesarean section. However, in the rare circumstances of a previous shoulder dystocia, after consideration of all factors and patient choice, or estimated fetal weights above 5,000 grams or 4,500 grams in diabetic patients, and the perfect storm of a large baby, a long labor, and an operative delivery, in these circumstances, no one should be criticized for offering prophylactic cesarean. To the contrary, from a medico-legal risk standpoint, to do otherwise seems a bit risky. Notwithstanding those rare cases, the college clearly states in the practice bulletin that studies failed to find any combination of risk factors that could accurately predict shoulder dystocia. Although risk factors can be identified, their predictive value is not high enough to be useful in a clinical setting. So we've learned that shoulder dystocia is overwhelmingly unpredictable. So unpredictable that it occurs as an unpleasant surprise. Thus, the proper management of the shoulder dystocia is paramount to prevent brachial plexus injury to the extent possible and to defend a malpractice claim. In learning proper management, it is important, I submit, to fully appreciate what type and degree of force can injure the brachial plexus. In studies done by Gonick, Allen, Crofts, and others, these forces have been determined. Most of these studies use the Newton as a unit measurement of force. As indicated at the bottom of this slide, 1 Newton is a unit of force of 22 pounds, so that 100 Newtons is a force of 22 pounds. The 1 Newton is a force of 0.22 pounds. Sorry about that misquote. As a bit of trivia, I'm sure you all recall that a Newton is really the force required to impart an acceleration of 1 meter per second to a mass of 1 kilogram. If you didn't remember that, just remember 100 newtons is equivalent to about 22.5 pounds. And I emphasize this because most of the studies that you will read will list newtons as the force measurement. It's not surprising, I think, to realize that contractions and maternal pushing effort in the second stage are very forceful. But I would not have imagined that 53 pounds of pressure is placed on the infant in the second stage of labor. Next are the typical axis traction, not lateral traction forces that have been measured in routine and difficult shoulder dystocia and operative deliveries. Excessive axis traction would most likely be applied in a forceps delivery since the vacuum cup will pop off at around 35 pounds. In one experiment on infant cadavers, over 100 pounds of axis traction was required to injure the spinal cord based upon a dissection of the cord. So fairly substantial axis traction force is required to harm a baby. In contrast are the lateral traction forces necessary to injure the brachial plexus that are listed here. Allen's paper cited studies done in infant cadavers. The neck was dissected after lateral traction at several force levels and then inspected for injury to the nerves. I presume that that inspection only qualified tearing and avulsion of the brachial plexus, so perhaps stretch injuries and bruises to the brachial plexus were not recognized. The infants who experienced brachial plexus injury in Croft's study that was determined in real-time deliveries had at least 100 newtons or 22.5 pounds of lateral traction applied. No infant to whom less than 22 pounds of lateral traction was applied had a brachial plexus injury. I think a digression here is important and timely. Not all brachial plexus injury is caused by excessive lateral traction. In some cases, brachial plexus injury occurs during the second stage when the sum of the contraction and Valsalva forces stretch the brachial plexus of the posterior shoulder impacted against the sacral promontory. In retrospective reviews in the literature, including one review of over 1,600 cases of brachial plexus injury, 46% did not even have shoulder dystocia. And there are few reported cases of brachial plexus palsy in babies born by cesarean section even before labor. So, absent shoulder dystocia or excessive lateral traction, a brachial plexus injury has another cause. To disimpact the anterior shoulder, one or more of the shoulder dystocia maneuvers listed here must be employed. Each one of these maneuvers permits the shoulder to deliver, not by force, but by increasing the space needed for the shoulders to fit through the outlet of the pelvis. This is nicely presented in a paper by Pogge and Spong from 2003. X-ray studies of the McRoberts position show a measurable 1 centimeter expansion of the anterior-posterior diameter of the pelvis. In the Rubin maneuver, by direct pressure on the anterior shoulder, thus squeezing the shoulders medially, or by rotating the shoulder to an oblique position, the shoulders fit through the pelvis. Delivery of the posterior arm effectively decreases the shoulder width, traversing the outlet by the diameter of the upper arm, increasing that width about 2 centimeters. The wood screw is actually the reverse of the Rubin's and probably is effective in the same mechanism that the Rubin's enjoys. We'll have plenty of time to practice the maneuvers on the mannequin when you do your training. This slide demonstrates the effect of the McRoberts position's increase in the AP diameter of the outlet by X-ray pelvimetry. The slide is a little difficult to follow on a quick glance, but the upper part of the slide shows an increase of 9 millimeters in the distance before and after in the anterior-posterior distance. In the Rubin maneuver, ideally the same hand as the presenting shoulder, the right hand for the right shoulder or the left hand for the left shoulder, is introduced into the vagina, under the pubis, until the fingers reach up over the baby's shoulder. Then there are two options. Either press the shoulder downward, hooking your finger into the axilla to slip the shoulder under the symphysis pubis, or rotate the shoulder into an oblique position and deliver it through a wider diameter. Delivery of the posterior arm is often touted as the primary disimpaction maneuver. It can be performed best if the posterior elbow is already flexed, since there is little space for easily reaching enough of the arm to actively flex the elbow. In my experience, for what it's worth, this is not an easy maneuver to do. The wood screw maneuver can be viewed as a reverse Rubin, if you will. It involves rotating the posterior shoulder anteriorly while applying some axial force, thus the screw mechanism. And as we saw in a previous slide, axial force does not injure the brachial plexus at the force levels that would be required to perform this maneuver. The posterior shoulder thus becomes anterior and is not then behind the symphysis. With the former anterior shoulder, now the posterior shoulder, delivery can proceed in standard fashion. This is called the prompt birthing simulator. It's manufactured by a company from England called Limbs and Things. Its pelvis is a replica of the bony pelvis of a female taken from CT scan dimensions. The baby mannequin is a replica of a 5-pound newborn. The baby has a strain gauge in its neck to measure the traction force exerted during a delivery. Annual shoulder dystocia training is required by the government of Great Britain. This provided a researcher obstetrician by the name of Joanna Crofts from England to conduct simulation training and publish several papers between 2005 and 2008 describing her group's experience with shoulder dystocia training using the prompt birthing simulator just seen on the preceding slide. She trained midwives, physicians in training, junior attendings, and senior consultants. After the physicians and midwives trained on the mannequin, she was able to measure how well those who trained were able to perform the shoulder dystocia maneuvers compared to clinicians who did not train. But the important point here is whether this training really does any good. If it didn't, we should take this mannequin and send it back across the Atlantic. But it does. It does do good. This is shown in the study outlined on this slide done by Draycott, one of Croft's associates, and Croft, who conducted a retrospective review of shoulder dystocia management and neonatal outcomes at the Southmead Hospital in Bristol, UK, where they actually conducted the shoulder dystocia training with the prompt birthing simulator. They compared 2 4-year periods, one from 1996 through 1999 before the simulation training, and the other from 2001 to 2004 after the annual training began. As the slide demonstrates, there was a consistent increase in the use of shoulder dystocia maneuvers after the training, while the incidence of shoulder dystocia did not change. This part of the research, I think, substantiates that what was learned in the training was retained over time and utilized. Most importantly, though, there was a 50% decrease in the incidence of brachial plexus injury at 12 months, along with all neonatal injury, fractured clavicles, and 5-minute APGAR scores less than 7. So I think we can conclude from this presentation several things. Shoulder dystocia is not uncommon. It may be underreported, however. It has numerous risk factors. It's unpredictable and unpreventable. Permanent brachial plexus injury is disabling and expensive, and about 10% of brachial plexus injuries are permanent. It is a source of significant malpractice cost with claims payments 50% above the average. Brachial plexus injury associated with shoulder dystocia may well be preventable in many cases. Training in the proper obstetrical maneuvers with simulation is effective, and proper performance of obstetrical maneuvers can prevent brachial plexus injury and malpractice claims. By doing training on the prompt birthing simulator, you'll be using the same mannequins that Dr. Crofts used in England and improved the skills and decreased untoward outcomes. This will be done in 2 phases. First, you'll learn by feedback how much force you are applying. And secondly, you'll practice performing the different obstetrical maneuvers to disimpact the anterior shoulder. And with this, it's my hope, and the hope of others interested in teaching this, that you will learn to reduce injury and enhance the defense of a malpractice suit if one is brought. Thank you very much for your interest and your attention.
What we're going to do here now is to show the training with the prompt birthing simulator that we've devised to train in 2 areas. First is to learn the amount of force that the clinician is exerting on the fetal neck and the brachial plexus. And we'll do that by learning the force that's being exerted by looking at a strain gauge, which is connected to the little fetal mannequin in here. And then we'll have that clinician be able to reproduce that force without looking at the gauge. After that, we'll move on to the second phase of this, which is to practice the obstetrical maneuvers to release the anterior shoulder. So the prompt birthing simulator is composed of 2 mannequins. The first is a hemipelvis of the maternal with the pelvis, the bony pelvis, reproduced from a CT scan of an actual female pelvis in the correct dimensions. The fetal mannequin is a 5-pound infant that has a strain gauge in the neck that will show the amount of strain on the brachial plexus on the neck with downward lateral traction. You can also practice axial traction with it. So if Dr. Herring, if you'll come over here, on on this side. Okay, just down like this. And what we'll do is just move off to the side over here. I think it might be a little bit better. What we'll do here, of course, in any shoulder dystocia, one of the first maneuvers is to, of course, call your team together, but put the mother into the Roberts position. This will increase the anterior posterior diameter of the pelvis about 1 centimeter. I'm going to, as a trainer, hold the mannequin by the legs to keep the clinician from performing the delivery, and also to keep the shoulder into an impacted position behind the symphysis pubis, which I can feel from the inside. Now, as I said, the first part of this will be doing the force recognition. So, Dr. Herring, what I want you to do is, with me holding this baby, let me grab it, good, back here. With me holding this baby, I want you to watch this strain monitor. The strain monitor actually is connected to the baby. It goes up to well above 200 newtons, which is about 45 pounds. And what we want the clinician to do is to recognize when he or she has gotten to 100 newtons, which is the threshold for injury to the brachial plexus. So watching the monitor, Dr. Herring, get to 100, try to recognize with your body motions and your feel when you've gotten to 100. Now I want you to do 3 times without looking at the monitor and get to 100 newtons. And let's see how good your recall is. Perfect. Right at 100, take the pressure off. Lateral traction down, 100, right on it. And let's do it again. Okay? This is easy to learn, and recall is unbelievably accurate when someone is training with the force monitor. The trainee can do this as many times as they want to get comfortable with it. We can rotate the baby into a right occiput transverse, ROA, LOA, different positions to determine which kind of force is being exerted. And the clinician can stand on either side depending upon which hand is dominant while we do this. The important thing is to allow the clinician enough room to be able to move the head down and to place the maternal mannequin close enough to the end of the table so that they can get downward traction. Okay. We'll also want to demonstrate the recording of the force on the computer here. The computer has a software package which not only will record the force monitoring, but will also record when the clinician is doing the different obstetrical maneuvers. And just to demonstrate that, I'm going to ask Dr. Herring to step back up here to exert some downward lateral traction. And if the camera can pick up the computer thing, now go back down. It goes back down to 0 and then back up to 100 if your recall is still good, and it is up to 100. And it's interesting, you can see where Dr. Herring, who's a very experienced obstetrician, was able to reach 100 without even thinking about it several times. Okay, now we're going to demonstrate how we're going to practice 3 maneuvers to disimpact the anterior shoulder. We're going to have Dr. Herring do the Rubin maneuver. Then he's going to do the wood screw to disimpact the shoulder, and then finally the delivery of the posterior arm. This is when the trainer has to really get busy, because the trainer has to hold the mannequin in an impacted shoulder position. And the best way to do it that I've found is to sit on the table, grasp the mannequin either by the legs or the arm to keep that shoulder up there. So let me get situated here. And up here. I'm going to have this baby's left shoulder, which is the anterior shoulder, caught up here behind the pubis. What Dr. Herring is going to do is to come up, and I think it's going to be probably best for them to see this, that you go on this side. Come up, and with his left hand, which may not be his dominant hand, but being the experienced obstetrician that he is, it shouldn't be a problem. He's going to go up under the symphysis. He's going to hook his fingers into the axilla, deliver the baby without hardly any strain. Now, I was watching the strain monitor with that, and he got up right to 100 newtons with that. Now, let's put it back in there. We're going to do this again. I'm going to hold this anterior shoulder up behind the symphysis. Dr. Herring's going to put his hands up under the symphysis. He's got nice, long, thin fingers. He's going to pull that down, and then again, 100 newtons. And I hope you could see that he was also doing some lateral traction on this, and we'll have to speak to him later about that to make sure he doesn't do that again. So the second maneuver we're going to do here is the wood screw. And in the wood screw, the clinician is delivering the posterior shoulder first. Again, it's almost like a reverse Rubin's, and the hand is inserted around the baby's back up to the axilla, and the shoulder is rotated obliquely to provide more room. So Dr. Herring's putting his left hand in the vaginal canal going posteriorly. He's got a finger in the posterior axilla. He's rotating, and his total axial, or his total lateral traction there was only 75 newtons, well within the safe zone. Let's do it again very slowly, and we'll break this down into parts. First, insert the left hand into the vaginal canal, then identify the shoulder and axilla, rotate obliquely, and deliver without any measurable unsafe lateral traction. Now, the final maneuver is the delivery of the posterior arm. We're going to give him a break by making sure that the posterior or right arm, the elbow, is flexed, so he does not have to perform a flexion maneuver. So he's going to use his right hand here, his dominant hand. He's going to go down straight posteriorly to the point where he can feel the humerus and the elbow. He's going to then move his hand down the arm and deliver the arm across the baby's chest and then out over the face. Maybe that I didn't have it placed correctly there. It's caught. Let me do. All right, let's do this again. I'm going to put this arm more in a normal position. Here it is. And let me flex the elbow. Okay. So I'm going to lift this shoulder up here too for you. Got the arm, the hand, is moving it up over the chest, across the face, out, and then without any effort whatsoever, the anterior shoulder delivers. The delivery of the posterior arm is a bit more difficult when the arm is not flexed. I'm going to deliver this little baby myself. And mention that in doing the posterior arm maneuver, if the arm is straight, what one has to do is to try to slide down across the humerus and then use these fingers to flex the arm. and then slide the hand down around the forearm and wrist and up over the chest and out. And that would be it. Is there anything you want to go, you want to go over again?
It was great.
Okay.
The only thing I don't think is there a way to capture a screenshot of this and we can put it in where they were talking about that? That would be great.
Let's do that.
Yeah, I don't know what you need to do that. If you can get a close up, how you'd get a close up, just to capture a screenshot of this, or maybe I don't know. Do you want us to print it and give it to you? Just do a screen capture of that.
And that we would just be focused on this right now?
Yeah, just to get a shot of it.
So I'll hold
Roland, how you doing? Here's your code. Yeah. Can it, you got it? Oh.
He's recording now.
Oh. We can tilt the screen up, down, left, right. Yeah,
So-
this is a little bit. Okay.
Is it moving? Is the screen moving?
You wouldn't be able to tell.
Well, I was just gonna
for
do this.
Shots.
There you go. We did real quick.
And I'll do it again so that you'll be able to capture it. One more time. That's what I've recommended is we have people do
Oh, okay. Are you doing it?
One more time. How high am I, Dan? Is that enough? Okay.